Welcome everybody. It's lovely to see a good number of you here with us today for what I'm sure is going to be a really interesting and informative session with Laura. So as Elisa mentioned, I work in the support services team here at Overcome. Some of you may be completely new to us, and so it's always a good opportunity to just give you a quick reminder really of all of the different ways in which we can support you. So we have our support line where you can give us a call if you have a particular question. Maybe there's a piece of information that you're looking for. You're preparing for your next appointment and you want to sort of talk things through. More often than not, people actually say, I just wanted to give a call and have a bit of a chat. And we're absolutely here for all of that. So you're very welcome to contact us that way. Likewise, you can reach us via email. We also have an instant chat feature on our website. And we have quite a busy members forum, which we call My Overcome. There's around 20,000 members on that forum these days, which is absolutely fantastic. And that is a really useful space where you can connect with others, largely from the UK, but abroad as well, and share your experiences, your questions, and really be met with a friendly welcome from our community of people affected by ovarian cancer. We run sessions like today, which we call our webinars. So this is where we invite along healthcare professionals, wellbeing facilitators, really experts in all different aspects of sort of living with a cancer diagnosis. And we also run our series of online support groups and workshop sessions, which are things like crafts, creative writing, gentle exercise. There's lots of ways you can get involved. If face-to-face support is more your thing, or you're looking to connect with people in person, we do run a series of events right across the UK, usually on a sort of monthly basis, and we try our best to kind of get around and about, across the spread of the UK as best we can. So there's lots of information and lots of ways to stay in touch. And the best way to keep on top of everything that is available is to become a member with Overcome. It's completely free to do that. And it just means that we will loop you in via email, our community news, to all of the different things that we have available for you to get involved with. I would like to introduce properly Laura to you. So Laura Cheetham is an advanced clinical pharmacist at the Northern Centre for Cancer Care, which is up in Newcastle. And we were really pleased to be able to welcome Laura to one of our events that I just mentioned, which took place up in Newcastle earlier this year. She led a really fantastic session there, which is largely along the lines of what she'll be covering today. So we wanted to really capture that and make sure that that wonderful presentation was going to be available to all of you, regardless of where you're based. And as Elisa mentioned, it will be made available on our YouTube channel. So you can come back to it, for the years to come, hopefully, until, the next update is due anyway. So Laura has specialised in her career in cancer services, and within gynae-oncology, she runs a pharmacist-led clinic for ovarian cancer patients who are taking maintenance treatments. Some of you on the call may be thinking, well, what's a maintenance treatment? This might all be quite new information. I'm not going to get into that. Laura is far better placed to be able to talk you through. And so what we will do, I'll pass over to Laura shortly. We hope to allow around 10 minutes for a Q&A at the end. Any questions that occur to you as we go, feel free to fire them in sort of as you think of them, and we will get to those at the end of the session. So, Laura, over to you.
Thank you for that lovely introduction, Alice. So, as I said, I'm an advanced clinical pharmacist. I work up in Newcastle at the Northern Centre for Cancer Care, and I've been doing a gynae-oncology-led clinic since around 2022. So I've got quite a few years of experience looking after primarily ovarian cancer patients who are on maintenance treatments that, as Alice mentioned, I will go into more detail about what that involves. So Just a brief overview of what I want to talk to you guys about today. So I'm going to mainly focus on targeted treatments. So that is, the bulk of it is essentially the PARP inhibitors. I think a lot of patients, whether you're on them or not, probably have heard of PARP inhibitors by now. They've really changed the mainstay of ovarian cancer treatment in the past, 5 to 10 years since they came into practice. There's another targeted treatment called trametinib that is only available for a very specific type of ovarian cancer. So I'll go into a little bit of detail about that. I'm then going to move on to hormonal therapies. So in patients that have a hormonally driven cancer, there's some other options we can use, and that's letrozole and anastrozole, and also tamoxifen that works slightly differently. And then I just want to talk to you about a few other bits and pieces as well. So I'm going to briefly give you an example of kind of how specific other drugs can interact with your maintenance treatments. Look into herbal remedies, because I think there's a lot that comes up, whether it's in clinic or whether it's the Overcome team getting questions about, is this safe? Should I be taking this? Because obviously there is a lot available online about potential benefits of herbal remedies. So I just want to touch base on that a little bit. And then also just who your team are and who might be looking after you during your cancer journey, and how you can rely on each of us individually. So what are targeted treatments? These are oral therapies that work on, in this case, they're oral therapies. We do have targeted treatments that can also be given parenterally, which is via the vein or via an injection. But in this case, we're looking at oral treatments that work on specific genes and proteins in the body that are involved in the growth and survival of cancer cells. So as a general theme, they target things about a cancer cell that make it a bit different from a normal cell. It's not foolproof. There are still going to be side effects because normal cells are still involved, but it's very different to traditional chemotherapy. So in the initial diagnosis with ovarian cancer, you'll likely have had chemotherapy with carboplatin and paclitaxel. That is what we class as conventionally cytotoxic. So that targets any cell in your body that is turning over at a fast rate, because that's what the cancer cells do, but also a lot of other cells in your body. And that puts you at increased risk of things like infections, upsets, all kind of your gastrointestinal tract, so your mouth, your tummy, your bowels. It's a bit different when we look at targeted treatments because they don't work in the same way. So they do still have side effects, but it's different from what you'd expect with normal chemotherapy. And also, even if side effects overlap with what you could have had with chemotherapy, you might find you didn't have any issues with chemo, but you do on targeted treatments, or vice versa, just because it causes the side effects in a very different way. So PARP inhibitors. You might have heard of Lynparza, which is olaparib, Rubraca, which is rucaparib, or Zejula, which is niraparib, or you might even be on one of these or have had treatment with these in the past. The way they work is by essentially preventing damaged DNA, which are the cells in our body that make up our genetic material, from being repaired. So DNA damage happens every day, whether that's due to external sources such as UV radiation, or whether it's due to something in our genetics or in tablets. Something happens that causes our DNA to get damaged. Normally, this is then repaired and we kind of go along and nothing else happens. In some patients, the DNA damage can lead to the development of mutations and problems with our cells that result in cancer cells developing. So the PARP protein is something that we all have in our body, and that has a job in repairing damaged DNA, and that allows cells to survive and grow. That's the same whether it's a cancer cell or a normal cell. We can give a medication called a PARP inhibitor, which are these three that I'm talking about now, the olaparib, rucaparib, and niraparib. And the PARP inhibitor prevents the PARP protein from repairing the damaged DNA. So the PARP enzyme can't attach itself to the DNA and cause the repair process that it normally does, because the PARP inhibitor blocks that mechanism. So that causes the cells to not be allowed to be repaired, essentially, and they die. This helps to control tumor growth because it can happen with cancer cells, but unfortunately it does also happen with some normal cells, and that's why we do still get side effects. So when a PARP inhibitor is prescribed, unless someone happened to be looking at second-line treatment during the COVID pandemic, when we had a nice little window for prescribing something a little bit different to what we are now, they're only used as maintenance therapy. So maintenance therapy is given after the upfront treatment, whether that's chemotherapy alone or chemotherapy and surgery. And it is given with an aim of extending your progression-free survival. So that's the period of time from when we give the chemotherapy and we either have cancer control or we've managed to get rid of the cancer, to the time that the cancer either starts to return or to the time it starts to grow if there is still remaining disease at the end of chemo with or without surgery. It can also extend the overall survival. So they aren't the be all and end all in that that's the chemo, but they do a really good job, especially in a certain cohort of patients, of giving you a longer period of time, either without having to go through chemotherapy again and without having to deal with cancer symptoms again, or even the possibility that the cancer is going to stay away in the long term. PARP inhibitors are most effective in those with BRCA mutations. So most of you will probably have heard of BRCA mutations in relation to breast cancer, such as Angelina Jolie, but it's also a common thing in ovarian cancer. So although it has implications from a genetics perspective and might mean that there is a family link and members of your family might also have the BRCA mutation, putting them at increased risk of a cancer, it does mean we can give you a better maintenance treatment, or a maintenance treatment that works better to try and keep the cancer away. They also work well in patients that have something called HRD, which is homologous recombination deficiency. And you don't need to remember that. It basically just means there is something in your genetic makeup that means your pathways for cell repair are slightly different. So it means we can kind of target things in a really clever way to prevent the cancer cells from being able to repair themselves and rejuvenate themselves. They do still have benefit in the absence of either of these things. So in patients that don't have a BRCA mutation and that don't have a HRD positive status, they can still work. We do still use them. In the first line setting, so that is after you've had your first lot of chemotherapy with or without surgery, there is a finite period of time that we're allowed to use them. And that's, well, I'll go on to that actually in the next slide. And that's due to what they did in the clinical trials. And that showed an ongoing benefit even after the medication was stopped. So if you get to X many years and your tablets are stopped because you've had a good response, then it doesn't mean the second you stop taking them, the cancer is going to come back. That the benefit from that 2 to 3 years on treatment is shown to be prolonged. And we now have data from 5 to 7 years after the clinical trial showing that patients are still responding really well, and we're still having that extended progression-free survival and extended overall survival. So this slide is maybe a little bit glaring. Sorry, I didn't really look at the colours very closely. But in the first line setting, the options we have available are olaparib, and that is only for patients that have a BRCA mutation. The initial starting dose is normally 300 milligrams twice daily. We can drop it down to 250 and drop it down to 200 in the case of toxicities and side effects. The dose to make that up is made of 2 different tablet strengths. So I do sometimes notice my consultants will just tell patients to take 1 tablet twice a day, and then they get to me 3 to 4 weeks later, and I find they've just been taking 1 tablet twice a day, but they should have been on 2. So at that point, they never have any side effects, but we have to then up it to the prescribed dose. So just make sure you're reading the label on your boxes if you are prescribed these. Olaparib is licensed for 2 years. So, sorry, approved for 2 years. So we stop it at the end of the 2-year mark unless there's a very specific indication that means we can apply for extended funding. We monitor bloods every 4 weeks for the first year. And then in the second year on treatment, we reduce that to 8 weekly, because by that point, patients should be pretty stable. We can also give olaparib in combination with an infusion called bevacizumab. So bevacizumab works in a slightly different way, and this essentially prevents the blood supply to your tumour cells. So we can kind of do a double-edged sword of targeting the PARP enzyme with the olaparib and targeting how well the blood is supplied to the cancer cells with the bevacizumab, and therefore we're kind of attacking the cancer cells from 2 different aspects. The olaparib is exactly the same as it is when it's given by itself. And the bevacizumab is an infusion, there should be an I there, sorry, every 3 weeks for 15 months. So that includes whether you've had any bevacizumab with your chemotherapy. So they can be used in BRCA mutations, but they can also be used in patients that don't have a BRCA mutation, but do have that HRD positive status. We monitor bloods every 3 weeks before the bevacizumab infusions, and then once the bevacizumab has stopped, we can reduce that to 8 weekly, because it's normally over a year into the olaparib at that stage. The other options we have are niraparib, which is another tablet formulation. It can be given whether you have a BRCA positive status or you don't have a BRCA mutation. They only come as 100 milligram tablets, and you'll either be told to take 3, 2, or 1 of them, depending on what we decide for a starting dose, and that's based on, with niraparib, your weight and also your platelet count, which is your blood clotting factor, when we start it, and then we can dose reduce if we need to. The niraparib is allowed for 3 years. For the first 4 weeks, we do have to check your bloods every week because there's an increased risk of your blood counts going off with this one. And I'll explain that in a bit more detail later on. For the second 4 weeks, or essentially the first 8 weeks in total, we monitor your blood pressure weekly because we know that the niraparib can cause your blood pressure to go up. After the first kind of 4 to 8 week period, we just go to 4 weekly. And then for the second and third year, everything is 8 weekly, providing things remain stable. Rucaparib is the other PARP inhibitor. So we cannot use this if you do have a BRCA mutation, but we can use it regardless of your HRD status. So the reason we kind of give different agents to different people is just dependent on what genetics we've got that we're working with. So rucaparib is a 600 milligram twice daily starting dose, and then there's a couple of different dose options to reduce. So we can go to 500, 400, 300, and that is, again, as you can see, made up of different tablet strengths. We give the rucaparib for 2 years, and again, we monitor, sorry, I found another typo. That should say first year 4 weekly and second year 8 weekly. We also have the option of giving bevacizumab by itself. So some patients don't want to be on a tablet for 2 to 3 years. They're happy just taking the bevacizumab infusion. We give it at a slightly lower dose if it's by itself. So that's 7.5 milligram per kilogram, and it's 18 cycles in total, including what you've had with your chemotherapy. So that's just a whirlwind tour of the options you might have as a first-line maintenance treatment. And we would normally, unless there were contraindications or a patient really didn't want them, offer at least one of these and give the patient the choice if they are eligible for multiple different options. So as I've mentioned, we do still get side effects. So the drugs work and we know how they work, but unfortunately that does affect other cells, not just the cancer cell. So we need to basically have people that are aware that we might cause some side effects and aware that we're here to help manage those side effects. So we have seen a lot of the side effects that we can get with these treatments, but they're still relatively new in the grand scheme of things with cancer therapies. So there are some side effects that might come up that we haven't seen before or that we don't know about from the trials. And the key thing that we have is our partnership between whoever you're seeing in clinic, whether that's your consultant, the registrar, a nurse specialist, or a pharmacist, and you. And having a strong, trusting relationship where you can open up about any issues that you do have helps us manage things much more easily than if you try and hide your side effects because you're scared it's going to get taken away. So nausea and vomiting is probably the key one that we see at the start, or one of the key ones. If patients do experience nausea and or vomiting whilst they're on PARP inhibitors, we would advise them, actually in general, would advise them to take the tablets at regular intervals with food. So the little leaf that you're going to get in your box doesn't say you have to take it with food, but we know in general it is much better tolerated if you have something in your stomach to start with. So I'd normally advise having it after your breakfast and your evening meal. We say 12 hours apart. If that's slightly less, then that's okay, just because we need to make sure that we're giving you it in a way that you can tolerate. If you are struggling with nausea, smaller meals more frequently is better than having large meals kind of 3 times a day and just snacking in the middle, trying to make sure that you're keeping your calorie intake up, but having it in a tolerable way for you. Avoid really strong flavours. So if you're feeling a bit sick, a massive curry is probably not the best plan. Natural remedies like ginger and peppermint can be really helpful. So whether that's in the form of herbal teas, peppermint tablets, even just polo mints or something like that, they can be. And ginger biscuits is another thing that patients sometimes have beside their bed to have with a cup of tea, and then they'll take the tablets. So there's ways to try and manage it without needing other medication. We know that caffeine and alcohol can aggravate nausea and vomiting, so just be cautious with intake of those. It's important to stay hydrated, so small sips of water. We're happy for you to have juice, tonic water, anything you like, but avoid grapefruit juice because that does interact with olaparib in particular. And we can also use anti-sickness tablets, and you might find that you've tried an anti-sickness tablet with your chemotherapy and it didn't help, but that doesn't mean it might not help with your oral maintenance treatment, because the way that they cause the nausea works in different ways. So it's always worth a shot, and then we can play around with things if that one doesn't work. As I've mentioned already, niraparib can cause some problems with your blood pressure. So that gets monitored weekly for the first 8 weeks on treatment and then monthly. If your blood pressure when it is getting checked is more than 140 for the larger number, which is called your systolic blood pressure, and more than 90 for the lower number, which is your diastolic, then we advise you to get some home blood pressure monitoring, and we'll liaise with your GP here. So we work across the teams because your GP is going to be a much better place to monitor your blood pressure at home and also amend your antihypertensives, which are tablets to control your blood pressure. They're the experts in that, not us. So it's a shared care system. So we'll basically tell you there's some issues with your blood pressure and then ask your GP to take over from there with the management and the monitoring. If your blood pressure spikes further, and if it's over 160 for the bigger number or over 100 for the smaller number, we have to withhold the niraparib just to make sure that we are giving it to you safely. We ask the GP to instate some antihypertensives, so some blood pressure management. Once the blood pressure is under control to an extent, we can reintroduce the niraparib, normally with a dose reduction, because in all likelihood, we're probably going to run into issues again if we start at the same dose. So changes to the bloods is the other thing that we see as kind of a key issue that obviously might not be something that you guys can feel, but it is something that we can see on the blood tests that we're checking. And we need to make sure that we've got things at a safe level to continue medication. So it can affect your bone marrow, and that is your hemoglobin, which is essentially a marker of anemia, your platelets, which are your blood clotting factors, and your neutrophils, which are your infection fighting cells. So if you do experience a drop in your hemoglobin, you're going to get classic anemia symptoms potentially. So that's shortness of breath, dizziness, pale skin, fatigue, a kind of feeling of a fast heartbeat on like palpitations in your chest. Depending on the level of the hemoglobin, we may or may not give a blood transfusion. And if you're symptomatic, we're more likely to give a blood transfusion to boost that back up. And then we'll probably start with a slightly lower dose depending on how low your hemoglobin dropped. Your platelets are the other one. So a low platelet level is called thrombocytopenia. That is essentially a sign that your blood isn't clotting as fast as normal. So if you bash yourself, you might notice there's a really nasty bruise that takes a lot longer to go away. Or if you cut yourself, it might take much longer to heal. You might experience nosebleeds. Some patients do get bleeding gums when they're brushing their teeth just from that added friction. Again, we're keeping an eye on this, and if this happens, we will pause your tablets until we can get that back up to a safe dose, and depending on how low they dropped, we might dose reduce going forwards. The final one from the bone marrow perspective is your neutrophils, and this is probably one of the ones that we're aware of from a chemotherapy perspective quite drastically as well, because we know that if our neutrophils drop and if our white cell counts drop, that means we can't fight infections in the same way. So if that does happen, we need you to keep a close eye on your temperature and let us know if you're feeling unwell. If the neutrophils do drop below a certain level, so we kind of allow a little bit of a reduction. We expect a bit of a dampening with these medications just because we know the way that they work. If it drops below a certain level, we'll go, actually, no, we're putting you at an increased risk of infection here. We're going to pause it, allow your counts to recover, and then look at restarting. Can also affect the biochemistry. So that's basically your kidneys and your liver. What we do know is the majority of these effects are what we class as transient. So if we stop the medication, things would normalize. And it tends to be that we'll see certain markers go up and increase in the first couple of months of treatment, but it's normally they'll do a jump and then they kind of stabilize. And as long as it doesn't continue to go up, then we don't need to do anything. We will simply monitor. Sometimes it will turn a corner and go back down again. Sometimes they will stay slightly raised for the duration of the treatment, but once we stop them, they'll go back. So it's unlikely that we'll really need to do much here, but you might get told that you need to increase your hydration if we see that your kidneys are going a little bit off, because it can just mean you're a little bit dry. Fatigue is another big issue with a lot of the PARP inhibitors in particular. So it's a mixture of things in that we know we're giving you a tablet that can cause fatigue. We're potentially causing you to be a little bit anemic, as I've just mentioned. Your body's also been through a lot at this stage. If you're on maintenance treatment, you've had chemotherapy, you've potentially had surgery, not just the physical aspect of that, but also the mental aspect. So try to listen to your body and not get too frustrated if you are feeling more tired than you were prior to your diagnosis. If you are someone that's quite active, try and spread those activities through the week. Plan the important activities when you have the most energy. If you do need naps, then that's okay, as long as it's not interfering too much with your day-to-day life. Light exercise can help, being cautious of driving if you are feeling tired, relying on your family and friends. But we also don't want to give you a maintenance treatment that destroys your quality of life. So if the fatigue levels are debilitating and they're interfering with what you want to do day to day, we can look at dose adjusting. And also we'll check your blood test just to make sure that we've not caused some anemia with the tablets. They can also affect your bowels, so can go one or two ways. They might cause you to be a bit bunged up, in which case you are struggling with constipation. So we just advocate like good hydration, so at least 2 litres of fluids per day, increasing the fibre in your diet, gentle exercise, and we can use laxatives if we need to. If things go the other way, we still need hydration because you're losing fluid if you've got diarrhea. Avoid alcohol, caffeine, dairy, high fat, high fibre foods, because that can also promote loose stools. Small frequent meals, and we can use Imodium, which is the tablet used to treat diarrhea and try and solidify things a little bit, essentially. The final one we're noticing a lot at the moment, and it didn't seem to be the case for my first couple of years doing this clinic, but recently I'm noticing a lot of ladies struggling with generalised body aches and pains, and also aggravation of underlying arthritis. So if you do already have an issue with kind of your hips or your knees or your finger joints, we can see that that does get worsened by the tablets. Simple pain relief is absolutely fine. So paracetamol, codeine, topical kind of ibuprofen gel or something like that. Before taking what's classed as an NSAID, so that's ibuprofen, naproxen, that class of drugs. If you want to take the tablets, just double check with your team just in case there is an increased bleeding risk or anything along those lines, because we know that there can be a slight overlapping side effect profile. We really advocate acupuncture, and that's something up in Newcastle that we can offer via the Macmillan service, and also Maggie's do auricular acupuncture, which is using your specific pressure points around your ears. I'm not going to explain this in great detail because I don't fully understand it, but it's specifically used for hormonal symptoms, which can also be the cause of the aches and pains. But it's more the hot flushes that the auricular acupuncture is for up here anyway. If you go private, then I think you can use auricular acupuncture for pretty much anything. We do think there's probably a hormonal element to the aches and pains as well. So although a lot of ladies with ovarian cancer are diagnosed postmenopausally, there's still a residual level of estrogen in your bodies once you've been through the menopause. Once you go through surgery, we are basically taking away any production of estrogen going forward. So you are more likely to potentially have a surgical menopause as well, and therefore the hormonal symptoms that you experience during the menopause might come back, and that is the aches and pains and the hot flushes and things like that. So if that is the case, we can very much look at whether we can address things from a hormonal aspect and how to best go about that. And I know up in Newcastle we're really trying to do a better job at addressing the menopausal side of things going forwards, because we're seeing so much of this recently. The other thing we do see is ongoing sensory neuropathy from your chemo. So if you've been on paclitaxel, there's a solid possibility you've still got some tingling in your fingers and potentially the soles of your feet. I've had a lot of ladies describe it kind of like walking on ice because they can't really feel their feet. It doesn't necessarily affect your balance, or it's just kind of a sensory issue. So we can try folic acid, which we can give for a couple of months to see if that does help with neuropathy. If that fails, we can try something called pyridoxine, which is another tablet that may help. Neither of these are kind of approved for this use, but they're approved for other uses, and we have data from like case studies and personal experience to say that they do sometimes help. The neuropathy can get better for up to 18 months after your chemotherapy. So if you are still struggling and it's been kind of 6 months or so, there is a possibility that's going to improve further. We can use other agents that we have licensed for neuropathic pain if there's kind of a burning or a shooting pain, but that's only duloxetine is the one that we normally recommend. But that's not going to help if it's just sensory. So if it's just kind of a tingling or a numbness, the duloxetine is not really going to do much. If you do have that burning or shooting pain, then it is something that might be beneficial. But again, liaise with your team, and we can always review this as we need to. So that's enough about PARP inhibitors. Moving on to the next targeted treatment, which is trametinib. So trametinib is only allowed for low-grade serous ovarian cancer, which is quite a rare subtype. It works by blocking a protein called MEK, which helps cancer cells to grow, and by doing that, it slows or stops cancer cell growth. The side effects can be quite similar, so it can cause high blood pressure, bleeding, diarrhea or constipation, nausea and vomiting. It can cause a fluid build-up, so if you notice kind of a swelling, especially in your lower limbs, if it's both sides rather than one side, then it might be related to this. And it can also cause changes in your liver function. So again, you'd be monitored in clinic and we'd be checking your bloods, but it's just side effects to be aware of if this were a medication that you were eligible for. So moving on to the hormone therapy. So in hormone receptor positive recurrent ovarian cancer, so not the first time there's a diagnosis, but the time the cancer comes back, we know that cancer cells grow in response to hormones in your blood, and that's your estrogen and your progesterone. So hormone therapies can work to reduce estrogen and progesterone levels, and that can hopefully stop or slow cancer cell growth. The options that we have are aromatase inhibitors, so that's letrozole and anastrozole. So the diagram labelled A basically shows that there's an enzyme in our body called aromatase that converts sex hormones, which are the androgens, into estrogen. And once the estrogen is created, it can bind to estrogen receptors on the cancer cell and drive cancer cell growth. If we give an aromatase inhibitor, that prevents the aromatase from working. So the androgens stay as androgens and they don't get turned into estrogen. So this essentially removes that go signal from the cancer cells because it can't bind. There's nothing there to bind to the estrogen receptor. So the cancer cell doesn't get that go signal. It doesn't grow. These are only licensed for postmenopausal women just because of the way they work. Tamoxifen is the other option. So this can be used post or perimenopausally. Estrogen binds to estrogen receptors on the cancer cells, as I've mentioned, and stimulates cell growth. But tamoxifen, instead of preventing the production of estrogen, binds to the estrogen receptors, which means the estrogen is just floating around and it's got nowhere to go because the target that it's looking for, that estrogen receptor, is blocked by the tamoxifen. And that prevents the estrogen from promoting cancer cell growth. So it's another way to kind of prevent estrogen and hormonally driven tumours from growing, but it doesn't fully remove estrogen from the body. The side effects of these are very much based on postmenopausal issues. So we see the joint pain, that's mostly your fingers, your wrists, your shoulders, knees and ankles. In order to try and help with this, we advocate for weight-bearing exercises. Weight loss is a really good way because obviously the less you're carrying, the less weight there is on your joints. Calcium and vitamin D intake just to protect your bones, and pain relief as and when needed. We do see that these medications can cause hot flushes, so that's a sudden intense internal heat in either the chest, the face, the head. Sometimes there's flushing alongside that, sweating, chills, obviously night sweats is the main thing that this relates to. We just suggest if this is happening, we can avoid triggers, so caffeine, alcohol, hot drinks, spicy food, smoking, stress. Loose clothing, don't have your bath or your shower too hot. We can look at drug treatment for hot flushes. So venlafaxine is one that we use quite frequently. Citalopram, escitalopram, paroxetine, fluoxetine, sertraline, clonidine. Only a couple of those are safe with tamoxifen just because of the way that the drugs interact, but it is something that we can look at. Most of these drugs are kind of licensed for use in anxiety and depression, so they are used for mental health conditions, but the way that they work, we know, can help with the hot flushes. We also see patients complaining of vaginal dryness on these medications, so symptoms of vulvovaginal atrophy, and that's strongly associated with the low estrogen levels in your body. So we can suggest topical moisturizers, skin-safe lubricants, hormonal vaginal creams, which we'd want to check with the team first. So we'd normally try the moisturizers and the lubricants before we're looking at any hormonal agents, just in case there is a slight risk that it can drive that cancer by giving a hormone therapy, even though it is just a topical agent. The other issue that we do need to be wary of with hormonal treatments is the risk of osteoporosis. And that's only with the aromatase inhibitors, because that's the one that's completely wiping out the estrogen levels. Estrogen is involved in maintaining healthy bones. It's common knowledge that postmenopausally, the risk of fractures and things goes up because you don't have that estrogen level in your body. We want to try and prevent that. So we can give things like bisphosphonates and denosumab, which are bone strengthening agents. And again, regular weight bearing exercise and calcium and vitamin D are really good ways to protect your bones. So moving on from me waffling about all the different oral treatments that you might be on or might be on down the line, and looking at herbal and dietary supplements. So as I mentioned at the start, we do get a lot of questions about, can I take this? I've read this is good. Is this okay? So there's a couple of things that we are okay with, and there's a couple of things that we'd actively say, please try not to take unless you're adamant you want to. So grapefruit and grapefruit juice can increase the toxicity of certain anti-cancer agents. So it's just something we really want you to avoid when you're on olaparib, tamoxifen, letrozole, or anastrozole, because it can cause increased side effects. St. John's wort is another one that works in the opposite way. So it can reduce the levels of different anti-cancer agents. So again, in general, please avoid this. If you really want to take it, just make sure you're not on olaparib, tamoxifen, letrozole, or anastrozole. Other bits and pieces like herbal drugs we get asked about. So there's garlic, turmeric, ginseng, kava, ginkgo, echinacea, and black cohosh. There is a risk that these tablets might increase the risk of bleeding, and they might also interfere with levels of the anti-cancer agents. So we'd prefer you not to take any of these, essentially, if you're on any of the oral therapies. Using garlic and turmeric in cooking is absolutely fine, as long as you're not chucking tons of it in. But like normal levels will be fine, but just don't take the supplements. The other bit that's been quite a lot of recently, I think especially, is mistletoe therapy and dog warming tablets for bendazole. These are completely experimental. We have absolutely no real evidence to say they're working. They're not tested alongside oral anti-cancer treatments, and febendazole in the UK isn't even licensed in humans. It's only in animals. So please avoid these. But if there's anything else that's not on that list that you're not sure about, then just ask your team. Things like vitamin D, calcium, iron, all absolutely fine. But if you're worried, just run it past whoever is reviewing you from a maintenance therapy perspective. The other thing to quickly touch on is drug-to-drug interactions. So if you are prescribed any new medications or short courses from your GP for kind of an acute infection or anything along those lines, it's just best to be cautious, because sometimes the anti-cancer drug levels may be affected, and sometimes the level of the other drug you prescribed might be affected. If one drug causes increased side effects of the other, you might see increased side effects. If one causes decreased levels of the other, we might have decreased effectiveness, essentially. Out of the drugs that we've talked about so far, olaparib is the one with the most drug interactions because of the way that it is broken down in the body. I've just listed a few things here just so you've got them for reference, with the slides being available, but things that you might get prescribed as a short course. So antibiotics, clarithromycin, erythromycin, antifungal agents, fluconazole, itraconazole, colchicine for gout. If you are prescribed any of those, it's best just to ring up and ask to get put through to whoever's looking after you from a maintenance therapy perspective, just so we can make sure that we're happy for you to take those. It might be that we just need to pause your maintenance treatment for the 5 to 7 days of treatment or whatever it is, just to prevent any increased toxicities or reduced effectiveness. Long-term medications that people might be on, I'm not going to read out that whole list, but it's there for you if you do need it. So it's just something that, again, if you are prescribed any of those, please liaise with your team just to make sure it's safe. And if you're in doubt about any other medications, please just ask. So just a quick one. I'm aware we want 10 minutes for questions at the end, so I'll try and go quickly. Other questions we get asked is, am I taking enough? How do I know that I'm taking enough of this medication, especially if I've had a dose reduction? And the answer is, these drugs at the levels that at the dose levels that I've explained at the start are all licensed doses, which means they've all been tested in clinical trials. We know that the beneficial effect that we've seen is from ladies that were on both the full dose or the intermediate dose or the lower dose. What's important is we give you a dose that you can tolerate. So there's no point in us giving you the higher dose and we have to pause it every couple of weeks because you've run into side effects and you're not tolerating it or your bloods have gone off. It's much better to be on a lower dose that we can keep you on long term for the duration of the 2 or 3 years than it is for us to stop and start. Having said that, a treatment break is absolutely safe. A couple of weeks off treatment to allow side effects to heal, or if you just wanted to feel better if you're going on holiday, that's absolutely fine. It's not going to cause any issues in the long run. Some patients, some lucky patients, don't have any side effects. It's rare, but it does happen every now and then. And I think there's a concern that if you've not got side effects, how do you know it's working? Again, we are giving you a tablet that has been tested. We know that the beneficial effect is there. If you don't have any side effects, your body just seems to tolerate it. That's great. We're checking your cancer marker. If you are concerned at any point, we can do a scan just to check up on things. But the likelihood is it's being as beneficial in someone that doesn't have side effects as it is in someone who is flawed with side effects. It just means you're lucky, essentially. Some of these side effects are similar to symptoms that patients have at diagnosis. There is that concern of, how do I know it's the tablet and it's not the cancer coming back? It's something that we need to address on a case-by-case basis. If it's that we start some tablets and then you start with these side effects, the likelihood is that is related to your tablets. And if we pause it and they ease off, then it's going to be the causative agent. It's unlikely that at the very start, if we start a medication and you develop these issues, that it's related to the cancer. Is much more likely to be the medication that we've just prescribed you. If it's down the line and things start and you're like, oh, this is weird, I've not had this before, and this is exactly the same as what I had at the start of my cancer journey, then just let us know. We can arrange a CT scan just to check up on things. Everyone has different experiences on these medications. Some people sail through, some people fall apart, some people are somewhere in the middle. It's just the way that your body tolerates them, and everyone's going to have a different experience because everyone's body is individual. And unfortunately, we can't always make predictions that are accurate in the cancer journey. A few other bits and pieces that we do get asked: am I immunocompromised? The answer is not in the same way that you were on chemotherapy, because we're giving you tablets that we want you to take in the longer term. We're trying to get you at a dose where your neutrophils and your infection fighting markers are normal, or as close to normal as we can get them we don't want them to be too low. So with chemotherapy, we give you your chemo, your counts plummet. So that means you're at an increased risk of infection about 7 to 10 days later, and then they recover before we give you a further cycle. With an oral therapy where we're giving it daily, we might dampen your immune system a little bit, but we're keeping it on a level playing field. If it drops too far, we'll pause it and we'll give you a reduced dose to try and maintain it at a healthy level. So essentially, no, you don't need to be as cautious in any way as you were on your chemotherapy. You can travel abroad, and we'd absolutely advocate people going away and going on holiday, especially after everything they've been through at the diagnosis stage. Just ask your team if you want a letter to say, keep your tablets with you in your hand luggage. Don't put them in the hold. So just so you've got them on them if anything were to happen with your hold luggage when you were going on holiday. If you're struggling to swallow any of the tablets we give you, please do not crush them or chew them. Ask your team. It is something that we have run into issues with a couple of times, and the majority of these medications, because of the way they act, can't actually be crushed. And we might cause more damage than good if that is the case, and it's something we need to review on an individual patient basis. If you miss a dose, don't take an extra dose, just take your next dose as normal. And yeah, that one missed dose or 2 missed doses isn't going to make a difference in the long run. The final bit, essentially, you're being looked after by a full team. So it's not just doctors. There's the people that you will interact with on a regular basis are likely to be doctors, nurses, and hopefully in most teams there is a prescribing pharmacist by now. We're not working in a pharmacist capacity, but we do have that expert knowledge of the drug side effects and things like that. But we're kind of working more as a clinician if we are doing your prescribing and your clinic reviews. We all communicate regularly regarding your care. The consultant is still in charge overall. If there's any issues, you can go back to them and we'll discuss things with them if we are concerned about anything. So they're still there. They just might not be the person that you see or speak to regularly. But essentially, it's a shared care input, and that means that you have expert advice from a variety of different healthcare professionals. So you're in the best place you can be. I won't go over that one, but essentially we're not just here for the management of your drugs and your side effects. We're also here for holistic support and signposting to anything that you do need. So if you do have any other concerns, please bring that up with whoever's doing your clinic reviews, and we can try and look after you in the best way possible. Sorry, that was a whistle-stop tour. Any questions? I will stop sharing my slides now.
Brilliant. Thank you so much, Laura. I'm amazed that you managed to get through all of that, and you did a fantastic job. No, really interesting. I think I always learn something when I dial into these webinars, and this is no exception. But I think the way in which you presented that was really clear, And, as we said at the start, everybody who is listening in today, if you haven't been taking notes, please don't panic, because these slides will be available as part of the recording. So you'll be able to watch back, pause the bit that you're interested in. And obviously, if you have any follow-up questions, then you can get in touch with us as well. So we have had a few questions come through, which is brilliant. So I will start with, let's have a look. Somebody has asked, they said, I am on olaparib and bevacizumab indefinitely. I have been on it for nearly 3 years, and I find I'm getting more and more fatigued and sometimes more aches and pains. So first question is, do the side effects get worse over time? And then secondly, what would you recommend to lessen the side effects? This person is considering coming off the treatment, although she's been advised that it's likely the cancer would come back if she does. So sort of a two-part question there. Do the side effects get worse over time? And then what would you recommend to lessen side effects?
So I think this must be a bit of an unusual case in that we don't actually usually give olaparib and bevacizumab for that long. So bevacizumab is normally only 15 months and olaparib is normally only 2 years, but we do have the option to extend that one if you do have what we class as stable residual disease. Obviously, I don't know the clinical background. It's a bit different in second line in that you can be on olaparib longer term, or other PARP inhibitors longer term, but I've never seen us use bevacizumab beyond that period of time. There is a possibility the side effects are cumulative. We normally see that side effects are worse at the start, but we do see some patients do kind of start to struggle further on in treatment in that they've just essentially not had a break. So you've been on, I'm assuming you had chemotherapy, I don't know if you had surgery, but then you've gone on to this maintenance treatment and you've been on that for X amount of time. It's probably just that your body's a bit worn out. Without knowing the clinical background, I don't feel like I can advise on kind of stopping versus continuing. The aches and pains being the main issue, it might be worth seeing if there is any kind of acupuncture or something along those lines if you've not tried that. I don't know what dosing you're on, so whether there is scope to dose reduce just to see if that helps ease things off. And yeah, pain relief from your GP or simple analgesia is probably the main things that I can recommend. But yeah, it's hard without knowing the full background to the case.
Of course. No, thank you, Laura. And yeah, just to clarify for you and for anyone else on the call, this person has just further commented that they're receiving private treatment, which is why their sort of treatment has been extended. We have had a question around the creams that you can use. I believe this is probably in reference to the section on like vaginal atrophy and vaginal dryness. Correct me if I'm wrong, the person that put that question in. But yeah, are there any particular products, I suppose, is the ask here?
Yeah, so I think the natural skin safe lubricants that we normally recommend is Silk and Yes. So I think one of them is specifically licensed for kind of vaginal atrophy and menopausal symptoms. I think the other one is just kind of a normal lube that you can buy. But they're both safe and meant to be quite effective. And I know that's what we recommend in our patients undergoing radiotherapy to the area as well. So they're the ones that we'd normally kind of go for as a first line treatment, see if that would help.
Brilliant.
So that's Silk, SYLK, and then the other one is just...
Yes, brilliant. We've had a couple of questions in relation to sort of foods, really. And just to highlight to anybody on this call, we have quite a few webinars on our website with a couple of dietitians and sort of cancer dietitians that we work closely with. So if you have any questions specifically about sort of dietary supplements or particular foods, I would really signpost you there as well. But I don't know if you can comment particularly on these, Laura, but we have been asked, or someone's commented that they were told to have soy in moderation or to avoid soy really with olaparib treatment. And somebody else is asking about pomegranates, which is a new one on me. So I don't know if you know about those.
Soy, I'm not sure about it. It's something I would have to look up. I've never been asked the question. There is I can kind of see the rationale in that, maybe in moderation rather than having loads of it. I think there's a possible link with a drug interaction, but I wouldn't want to be quoted on that. It was something I would have to look into, and I'm happy to do that after the webinar. Pomegranate, I've not heard of any issues. Again, I can double check, but it's not something that I've come across. And it's not one that, it's not like grapefruit is the main one from kind of normal dietary things that jumps out. But as far as I'm aware, pomegranate should be okay, but I would be very happy to double check and make sure that I'm giving the correct advice with that one.
Yeah, no worries. Absolutely. And, for anybody that does have questions about particular foods, you can ask for your team to connect you with an oncology dietitian. That is really their area. We would be happy to take questions as well, and try to get an answer to you. If there's anything along those lines that you're concerned about, then do get in touch. Where are we? So we've got just a couple of minutes. What I will say is we're not going to have time to get to all of these questions today, which is what Laura and I predicted. Laura has very kindly offered that we can collate any questions that haven't been asked and get answers out to attendees of this session via email. So obviously we don't want to bombard her, but just to rest assured that we will try to get an answer to you. So just note to Elisa, if you can make sure that we're kind of copying down the questions that are coming in, and then we'll make a note. So someone has asked, I've been prescribed rucaparib, 300 milligrams, 2 tablets twice a day. I cannot have the infusion due to an operation on my bowel. Does this make my treatment less effective?
No. So we can only give whatever maintenance therapy is safe. So if there are issues with the bowels, then we do sometimes avoid bevacizumab because we know it can cause something called gastrointestinal perforation. So there's a risk that we're going to cause a lot more harm than good. So there's no point in giving you a medication that is going to potentially cause really serious side effects. We'd much prefer to give you something that is safe. Rucaparib is tried and tested. It is a very effective option. So the fact that you're on rucaparib rather than what I'm assuming when you said the infusion is the bevacizumab, it's just the safe option for you. And we very much have the data to support its use. So you've not been given an inferior option. You've been given the safe option for your individual case.
Brilliant. Thanks, Laura. And as I said, we're not going to be able to have time to get to all of these, but I thought I'd read one which I think hopefully is a lovely thing for you to hear. Someone said, fantastic presentation. I was fortunate enough to have you involved in my care. Currently traveling through the Picos Mountains in Spain, which is brilliant. And there is a question that follows that, but I'm afraid we will have to draw the session to a close. We don't want to take up too much of Laura's time, which is very generously, given to all of us today. So we will collate the questions that we have not had an answer to, and obviously we'll send to Laura those that she's well placed to answer. And if there are any that we think, we can go to our, dietitians that we work with, then we will be able to get some answers to you. And having lots of thank yous come in. So thanks so much for being here and for your engagement with this session, everybody. And, keep your eyes peeled on our website for everything else that we have coming up as well. And thanks again, Laura, for your time. We'll end there.
Thank you for having me.
Thank you.